look at those. And if there are any suggested adjustments, amendments, changes, let's hear from you.
I noticed Dr. Smith's first name is misspelled on number 8B1 the second time, and then on number 11. She's missing the E in Catherine.
Thank you, Dr. Siegfried.
Thank you. Are there any other adjustments we need to make? With that edit, I would accept a motion to approve.
I move to approve.
And do we have a second?
I can second.
Thank you. All in favor, we say aye.
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 Thank you. Minutes of April 2025 are approved. Now we have a lot of items on the agenda today, so I'm going to get right to it. And I think our first report, if we can move to the agenda. Thank you.
Let's see. And so, Dr. Wen, do you have an update for PNT?
No new update for PNT versus last meeting. PNT will meet next week to review, but no new update.
Thank you.
Thank you for that. Now we are on to our first item.
Yes, thank you. Good morning, everyone. So today I will discuss some key considerations regarding the prophylactic use of Alhemo, hereafter referred to as concizumab, for congenital hemophilia. Additionally, as relevant throughout the presentation, I'll touch on other hemophilia prophylactic agents approved prior to concizumab for comparison. Congenital hemophilia A and B are rare X-linked recessive lifelong bleeding disorders characterized by a deficiency of clotting factor 8 or 9 respectively, which are essential for maintaining hemostasis. Therefore, patients with hemophilia A or B may experience potentially life-threatening, spontaneous, and/or trauma-induced bleeding, including recurrent joint bleeds. The standard of care for these conditions involves the use of replacement therapy with plasma-derived or recombinant factor 8 or 9 concentrates, which are used for both bleed prevention, depending on the patient's disease severity, and on-demand management to control active bleeding episodes. However, a significant clinical challenge arises with prophylactic therapy when patients develop anti-factor 8 or 9 neutralizing antibodies known as inhibitors, which substantially increase the risk of bleeding-related hospitalization by rendering factor replacement therapy ineffective. Inhibitors are more often observed in patients with severe hemophilia compared to those with mild or moderate disease, and occur more frequently in hemophilia A than hemophilia B. Although inhibitor development tends to be less common in patients with hemophilia B, it is frequently associated with severe allergic reactions to the factor 9 product. Most patients with hemophilia A or B are diagnosed before 2 years of age, with severe cases typically diagnosed in the first month of life. Approximately 2/3 of infants diagnosed with hemophilia have a family history of the disorder. In the remaining 1/3 of cases without a known family history of hemophilia, diagnosis typically follows an abnormal bleeding event. While coagulation laboratory tests can be used to help differentiate other bleeding disorders from hemophilia, a definitive diagnosis of hemophilia in general is made based on factor assay testing. Differentiating congenital hemophilia from other conditions entails consideration of the patient's family history and genetic variant and/or exclusion of other conditions that can cause low factor 8 or 9 levels. Genetic testing is recommended to be offered to all patients with hemophilia A or B and their at-risk relatives. Notably, the severity of bleeding manifestations are generally dependent on the extent of clotting factor deficiency. Testing for inhibitors is performed regularly during factor replacement therapy, including before surgery, after initial or intensive factor exposure, and when the patient's response to replacement factor concentrates is suboptimal, especially after prior responsiveness. The Centers for Disease Control and Prevention advise that all patients with hemophilia who receive factor concentrates be tested for inhibitors at least once a year. Likewise, the World Federation of Hemophilia, abbreviated WFH, recommends screening for inhibitors in newly diagnosed patients with hemophilia A or B at least every 6 to 12 months after starting factor concentrates and annually thereafter. Uniquely for hemophilia B, the WFH also recommends to screen for inhibitors in patients who develop an allergic reaction to factor IX therapy, as it may be an initial sign of inhibitor development. A positive inhibitor titer that is less than or equal to 5 Bethesda units is classified as a low titer or low responding inhibitor, while greater than 5 Bethesda units is classified as a high titer or high responding inhibitor. High titer inhibitors tend to be persistent and are associated with a poor response to factor replacement therapy, requiring alternative treatments to prevent or control bleeds. In contrast, low titer inhibitors may be transient, with bleeding episodes potentially treatable with more frequent and or higher doses of factor concentrates to overcome the inhibitor. Immune tolerance induction, or ITI, is an optional therapy that can be employed as a strategy to eliminate inhibitors, particularly in patients with hemophilia A. ITI is generally considered a failure if inhibitor levels remain high after an adequate amount of time on ITI therapy. ITI is associated with a failure rate of approximately 20 to 40% in hemophilia A and 70% in hemophilia B. Concizumab was approved by the FDA in December 2024 for routine prophylaxis to prevent or reduce the occurrence of bleeding episodes in patients aged 12 years or older with hemophilia A or B and inhibitors. Other agents approved for routine prophylaxis of hemophilia A and or B in patients with inhibitors include imicizumab or Hemlibra, anti-inhibitor coagulant complex, abbreviated AICC or FIVA, and the antithrombin agent fitusiran, just approved in March 2025. Regarding the older agents, imicizumab is indicated for routine prophylaxis in pediatric patients as young as newborns and adults with hemophilia A with or without inhibitors, but is not approved for hemophilia B. In addition to routine prophylaxis, AICC is also approved for the control of active bleeds and for perioperative prevention of bleeds in patients with hemophilia A or B and inhibitors. Although the labeling for AICC does not specify age restrictions, safety and efficacy have been studied for routine prophylaxis in pediatric patients as young as 7 years of age. While all products facilitate clot formation to achieve hemostasis, their mechanisms of action differ. Concizumab is a humanized immunoglobulin G4 monoclonal antibody that blocks activity of tissue factor pathway inhibitor. Imicizumab, also immunoglobulin G4 monoclonal antibody, acts by dually binding to activated factor 9 and 10, thereby activating factor 10 to allow for continued functioning of the coagulation cascade in the absence of factor 8. The bypassing agent, AICC, is a plasma-derived activated prothrombin complex concentrate, abbreviated APCC, that contains a mixture of coagulation factors, thus bypassing the need for factor 8 or 9 by directly triggering thrombin generation and clot formation. Concizumab, imicizumab, and AICC are dosed according to body weight, with long-term concizumab maintenance dosing based on drug plasma concentrations. Concizumab and imicizumab are administered as subcutaneous injections, and AICC is administered as an intravenous injection or infusion. Notably, AICC requires aseptic reconstitution and a controlled injection or infusion rate, whereas concizumab and imicizumab can be more easily administered by patients or their caregiver upon training. Unlike imicizumab that requires the transfer of vial contents to a syringe for administration, concizumab is available as a ready-to-use multi-dose prefilled pen. Initiation dosing for concizumab involves a loading dose of 1 mg per kg on the first day, followed by 0.2 mg per kg daily until the drug plasma concentration is assessed no later than 8 weeks after starting therapy, at which point the dose is adjusted according to drug plasma levels. Imicizumab also requires an initial loading dose, but has a longer duration of action than concizumab. It is given once a week for the first 4 weeks, followed by a weekly, biweekly, or monthly maintenance dose, depending on the provider or patient preference. The prophylactic regimen for AICC is 85 units per kilogram every other day, delivered intravenously. We reviewed 2 international hemophilia guidelines regarding the prophylactic treatment of hemophilia A and B in patients with inhibitors, one each from the International Society on Thrombosis and Hemostasis, or ISTH, and the WFH. Additionally, we reviewed relevant guidance statements from the Medical and Scientific Advisory Council, or MASAC, of the National Bleeding Disorders Foundation, published within the past 5 years. Notably, the ISTH guideline does not provide formal graded recommendations for hemophilia B in patients with inhibitors. All review guidances predate FDA approval of concizumab and therefore do not address its use. Nonetheless, I'll review recommendations regarding prophylaxis in general. Guideline recommendations or guidance points were referred to apply to children, adolescents, and adults with hemophilia A or B, although not always explicit. The WFH recommends continuous long-term prophylaxis as the standard of care for patients, especially children with severe phenotype hemophilia A or B. In addition, the WFH recommends early initiation of prophylaxis, ideally before 3 years of age, in pediatric patients with severe hemophilia A or B prior to the onset of joint disease. Likewise, the MASAC endorses early prophylactic treatment as the standard of care for patients with hemophilia A or B and a severe phenotype, including those with inhibitors. The ISTH conditionally recommends prophylactic over on-demand only treatment for patients with severe hemophilia A and inhibitors. While reviewed guidances do not explicitly define severe phenotype, the ISTH notes that the definition may follow clinical judgment, particularly in patients with non-severe factor deficiencies. Based on expert opinion, we infer severe phenotype could be concluded based on having a severe factor deficiency and/or frequent or severe bleeds, regardless of the degree of factor deficiency. Specifically for prophylaxis therapy and severe hemophilia A with inhibitors, the ISTH, WFH, and MASAC prefer imicizumab over bypassing agents such as AICC, as imicizumab is less burdensome to administer and may be more effective compared to bypassing agents. For prophylaxis therapy in hemophilia B with inhibitors, selecting a bypassing agent depends on prior hypersensitivity to factor IX. APCC is recommended for patients without a hypersensitivity to factor IX, whereas recombinant activated factor VII is recommended for those with a hypersensitivity to factor IX. Importantly, even with prophylaxis treatment, regardless of the selected agent, patients with hemophilia may experience breakthrough bleeding, possibly requiring concomitant on-demand use of additional hemostatic agents. Generally, acute bleeding episodes in patients with hemophilia A or B and inhibitors are managed with high-dose factor concentrates for those with low-responding inhibitors or bypassing agents for those with high-responding inhibitors. No published head-to-head randomized control trials are available to compare the efficacy and/or safety of concizumab to imicizumab or AICC for prophylaxis therapy. FDA approval of concizumab was based on a multi-center open-label phase 3 trial, Explorer 7, which evaluated the safety and efficacy of once-daily subcutaneous concizumab for routine prophylaxis compared to on-demand only treatment with bypassing agents in patients 12 years of age and older with any severity of hemophilia A or B and inhibitors. To be eligible for the study, randomized patients must have been previously prescribed or treated with bypassing agents in the 24 weeks prior to screening. Patients were excluded if they had a clinical history or evidence of thromboembolic disease, were high risk for thromboembolic events based on investigator judgment, had current or planned ITI therapy, or received imicizumab within 180 days prior to screening, among other criteria. Explorer 7 enrolled a total of 133 patients with inhibitors, of whom 80 had hemophilia A and 53 had hemophilia B. Of the entire study population, the mean age was 29 years, with approximately 32% adolescents. While the study included 2 randomized groups, it also had 2 non-randomized groups that received concizumab prophylaxis. However, because the primary efficacy outcome was with respect to randomized patients, I'll focus primarily on results for the 2 randomized treatment groups. In March 2020, concizumab treatment in the Explorer 7 trial was temporarily halted due to non-fatal thromboembolic events that occurred in 3 patients treated with concizumab during the phase 3 trials. All 3 patients were found to have thromboembolic risk factors at baseline and had concomitantly used other hemostatic medications at high or frequent doses either prior to or on the day of the thromboembolic event. Explorer 7 was initially designed with a concizumab fixed maintenance dose of 0.25 mg per kg per day, following the 1 mg per kg loading dose on the first day of treatment. However, after these thromboembolic incidences, the maintenance dosing protocol for concizumab was modified to tailor dosing according to the patient's plasma drug concentration. Guidance was also issued for managing mild and moderate breakthrough bleeds. Use of the lowest approved dose of acute hemostatic agents with dosing interval restrictions was recommended. Regarding baseline bleeding rates, 63.2% of patients in the no prophylaxis arm and 69.7% of patients in the concizumab prophylaxis arm experienced more than 9 bleeds during the 24 weeks before screening. Notably, the actual number of bleeds was not reported, such as the baseline average annualized bleed rate in each arm, nor was information provided regarding patients' levels of factor deficiency. However, the FDA review describes that hemophilia severity was expected to be similar between randomized groups based on stratification of the historical bleeding rate in the preceding 24 weeks. The median number of target joint bleeds within the past 12 months was similar between treatment groups. Efficacy for the primary analysis was evaluated once all patients in the no prophylaxis arm and concizumab prophylaxis arm had completed at least 24 weeks or 32 weeks of treatment respectively, or had withdrawn. For the primary analysis, patients in the concizumab arm who restarted concizumab at the revised dosing regimen contributed data only while on the revised dose. Concizumab prophylaxis demonstrated superiority over no prophylaxis for the primary outcome of the mean annualized bleeding rate, or ABR, of treated spontaneous and traumatic bleeding episodes compared to on-demand only therapy. Note that the outcome assessment is regarding the ABR while on treatment. It was not a change from baseline assessment. Sensitivity analysis for the primary outcome indicated that the results remain unaffected by the treatment pause for concizumab. Regarding select patient-reported secondary outcomes, results did not significantly differ between treatment groups for the mean change from baseline to week 24 and bodily pain score on the 36-item short-form health survey version 2, but trended toward favoring concizumab prophylaxis. Among all patients who received concizumab, including those in non-randomized groups, 63% experienced any adverse event, with the most common being joint pain, redness at the injection site, upper respiratory tract infection, and increased levels of prothrombin fragments 1 and 2. Injection site reactions were reported in 20% of all patients who received concizumab, with most being mild in severity. Hypersensitivity type reactions occurred in 2 patients, both of whom received concizumab, leading to permanent drug discontinuation in both cases. While one patient in the randomized concizumab prophylaxis group experienced a renal infarct before the treatment pause, no additional thromboembolic events or other safety concerns have emerged following the restart of concizumab treatment, according to longer-term data at 56 weeks. Both concizumab and AICC are contraindicated in patients with a history of serious hypersensitivity reactions to the drug or any of its excipients. Additionally, AICC is contraindicated in patients with acute thrombosis or embolism or disseminated intravascular coagulation. Imicizumab does not have any labeled contraindications. Both imicizumab and AICC have a similar black box warning for thrombotic or thromboembolic events. Likewise, concizumab has a warning regarding thromboembolic events, although it is not elevated to the status of a black box warning. Other warnings and precautions in common with concizumab, imicizumab, and/or AICC are hypersensitivity reactions and laboratory abnormalities or test interference. Imicizumab has a unique warning for immunogenicity, and AICC carries a unique warning for the potential risk of transmitting infectious agents as it is derived from human plasma. With respect to developing drug-specific prior authorization or PA criteria for concizumab, we recommend requiring that patients meet the FDA-approved indication based on provider attestation and/or clinical documentation. While the FDA indication does not require a specific disease severity nor a certain threshold for a factor 8 or 9 inhibitor titer, it may be reasonable to require that patients demonstrate a history of an inhibitor titer of greater than or equal to 0.6 Bethesda units, corresponding to patient inclusion criteria for its pivotal clinical trial, Explorer 7. Other criteria to consider include confirming that the provider plans to tailor the patient's maintenance dose no later than 8 weeks after starting treatment based on concizumab plasma levels in accordance with the FDA-approved labeling, and that the provider or patient has a plan for managing acute breakthrough bleeds while on concizumab, as prophylactic agents may not prevent all bleeds. If desired, additional PA criteria based on provider attestation or clinical documentation could also be considered, such as those listed here. To highlight a couple of ideas, you may consider requiring concizumab be prescribed by or in consultation with a hematologist, or that the patient will not undergo ITI therapy or other long-term prophylactic therapy during use of concizumab, as such concomitant therapy has not been adequately studied to determine the safety. Thank you for your time and attention, and please let me know if you have any questions.
Thank you so much for that summary. Excellent review. And I think we're going on to the next presentation. Is that right, Dr. Moreno?
Yes. All right. And so yes, this is for Qfitlia or fitusiran. And here's the agenda. So this medication was approved by the FDA on March 28th, 2025 for the routine prophylaxis of bleeding episodes in patients 12 years of age and older with hemophilia A or hemophilia B, with or without factor 7 or factor 9 inhibitors or neutralizing antibodies. Qfitlia is a first-in-class antithrombin-directed small interfering ribonucleic acid therapeutic that prevents bleeds by reducing antithrombin levels. And as these levels are reduced, then that leads to an increase in thrombin to enable blood clotting. The subcutaneous injection can be given once every 2 months. And also, here's some clinical information. The dose and frequency of injections should be adjusted based on antithrombin activity using the FDA-cleared Innovance antithrombin companion diagnostic test. Measuring the AT activity prior to initiation of Qlifta is recommended, and do not initiate medication if the antithrombin activity is less than 60% per the package label. And the starting dose of Qfitlia is recommended at 50 milligrams once subcutaneously every 2 months, and to adjust the dose and or dosing interval if needed to maintain AT activity between 15 and 35%. So that's very specific. In terms of the clinical trial overview, so there's a phase 3 open label randomized trial called Atlas AB, and that enrolled males aged 12 years and older with severe HA or HB without inhibitors. So that's patients lacking inhibitors. And then randomly assigned to receive on-demand treatment with clotting factor concentrates or monthly Qfitlia 80 milligram fixed dose injections for 9 months. So this first trial is for patients without inhibitors. Phase 3, the second trial, called Atlas INH. It enrolled patients with HB, HA and HB who did have inhibitors and received on-demand bypassing agents or BPAs or monthly Qfitlia 80 milligram for 9 months. And so the fixed dose of Qfitlia 80 milligram monthly resulted in excessive clotting in some patients. Then from here, we go to the third trial because of these thrombotic events observed with the fixed dose of Qfitlia 80 milligram monthly. So patients from these first 2 studies were rolled over into a long-term extension study called Atlas OLLD. And the dosing was based on antithrombin activity of 15 to 35% in that study. And the efficacy and safety from dosing based on AT activity was then compared to with the control data from the previous 2 studies, Atlas AB and Atlas INH. So for Atlas OLE, it included males 12 years of age and older with HA or HB with or without factor 8 or factor 9 inhibitors. And the exclusion criteria here involved patients with known coexisting coagulation disorders, increased risk of thrombosis in patients with history of arterial or venous thromboembolism, significant valvular disease or atrial fibrillation, coexisting thrombophilic disorder, AT activity at less than 60% at screening, a platelet count less than or equal to 100,000 microliters, and eGFR less than or equal to 45 milliliters per minute, or clinically significant liver disease. And the primary endpoint was the estimated annualized bleeding rate, or ABR, of treated bleeds. And so in terms of the results, patients with inhibitors, so 73%, we saw a 70% reduction in the ABR in Qfitlia patients versus the VPA patients, and that was statistically significant. Patients without inhibitors, there was a 71% reduction in the ABR with Qfitlia patients versus those receiving the factor concentrates. Common adverse effects of greater than 10% included viral infections, nasopharyngitis, and also bacterial infections. In terms of the monitoring parameters, so Qfitlia does come with box warnings. One is the risk of acute and recurrent gallbladder disease, and the second is the risk of thrombotic events, especially when the antithrombin activity is less than 15%. Other risks include hepatotoxicity, and we need to monitor for liver function as recommended per the FDA label. In terms of utilization, since Qfitlia was just recently approved in March, we have no claims for Medicaid fee-for-service patients. And then same story with the Alhemo, which was approved in December of last year. We currently have no utilization to report. And that is it for my presentation. Are there any questions?
Thank you so much for that presentation. And I think we are on to our public comments.
Yes. We have first Dr. Dong from Sanofi talking to us about Qfitlia. And then she'll be followed by Linda Finch from Biogen with Skyclarys. And she will be followed by Kelly Madden from the Friedreich's Ataxia Research Alliance. And then we'll hear from Beth Lubelsick with Eli Lilly for Zepbound. And then lastly, we'll hear from Dr. Amy Hale with Johnson & Johnson discussing Spravato. And so each presenter has 3 minutes, and I will be keeping time. Go ahead, Dr. Duong.
Hey there. My name is Tumai Duong. I'm a pharmacist and I work for Sanofi. Thank you so much, Dr. Moreno, for the review of Fitusiran or Qfitlia. I guess a couple of comments in terms of, first and foremost, is that there was also another study. It was the Atlas PPX or prophylaxis study. And in that specific study, Fitusiran demonstrated that it was comparable to patients who were previously treated on prophylactic factor concentrates. And when there was a 70% reduction in annual bleed rates in patients who are on bypassing agents as prophylactic therapy. So that was an additional study that was also evaluated that was comparing against other active comparators who are also prophylactic as well. And I guess probably some of the final commentations on Fitusiran would be that it is not only first in class, but is currently the only agent that is approved across the entire spectrum of hemophilia. So that's hemophilia A and B with or without inhibitors. And potential for dosing, there's a potential for dosing, so there's a potential for the appropriate dosing and dosing in terms of it's every 2 months. It's subcutaneous, so that's not more than 6 doses a year. And it's coupled with, it's a fixed dose, so there's not a weight base. So that can help with dosing predictability. And using the antithrombin-based dosing regimen, it does allow for a nice balance between efficacy as well as safety. So those are some of the potential therapeutic advantages for Fitusiran.
Very good. Thank you so much. Any questions for Dr. Duong? All right, Dr. Finch, the floor is yours.
Thank you. And I'm speaking about Skyclarys. So did you want me to go at this point, or is it a little later in the, okay.
Yeah, go ahead.
So good morning. My name is Linda Finch, and I'm a medical account director for Biogen. We are the manufacturer of Skyclarys, or omaveloxolone, which is approved to treat individuals with Friedreich ataxia, or FA, for age 16 and older. FA is a rare progressive neurodegenerative disease, and it's estimated to affect around 5,000 individuals in the U.S. And Skyclarys is the first and only treatment currently indicated for FA. And for the sake of time today, I'm going to just discuss the trial results as well as our open label extension and provide some considerations for potential coverage criteria if you're going to be evaluating those today. So FA is a relentlessly progressive and neurodegenerative disease. It leads to loss of coordination, lower limb movement, independence, and ambulation. And even after wheelchair dependence, this progressive multi-system disorder continues to affect the upper limbs, motor strength, reflexes, hearing, vision, cognition, and cardiac function. And ultimately, these individuals have a premature death around age 37. So untreated Friedreich ataxia patients have a progression of around 2 points per year as assessed by the Modified Friedreich Ataxia Rating Scale, or mFARS. And Skyclarys has been shown to slow this progression. Patients treated with Skyclarys achieve statistically significantly lower mFARS scores compared to placebo at week 48 in the clinical trial, and 55% slower progression at 3 years compared to matched untreated patients from a large natural history study. I want to mention that the mFARS is a validated neurologic assessment tool. It was designed to assess FA progression at a population level, not individual patient level. So it's not commonly used in clinical practice, even by specialists. So I would not recommend including that in your criteria. So FA is typically diagnosed and managed by primary care providers with confirmation by neurologists who use a standard neurological exam for following these patients. And requiring the mFARS can present a barrier to patients. Providers are not familiar with it. It has a significant time requirement. And it's also heavily weighted towards upright stability, so it's not appropriate for evaluating non-ambulatory patients. And we did evaluate non-ambulatory patients in our studies, and they do respond to treatment with Skyclarys at a level similar to the overall population. I also want to mention the mFARS range that we used in the clinical trial. So we studied a range from 20 to 80, mainly to minimize variability because patients that are very early in their disease or later in their disease have much greater variability in their symptoms and rate of progression. And so not because of a belief that they wouldn't respond to treatment. So those patients shouldn't be excluded as well. And then lastly, I want to address pes cavus. So most patients with FA have some degree of pes cavus. It's essentially a high arch foot condition. And 75% of patients in our trial did have some degree of pes cavus. Okay,
That's time.
thank
Thank
you.
you, Dr. Finch. Appreciate it.
Thank you.
All right, let's move on to presenter Kellen Madden, please.
Thank you. Hi, my name is Kellen. I work for the Friedreich's Ataxia Research Alliance, or FARA, and we are a national nonprofit organization dedicated to advancing treatments for FA. The previous speaker did a really great job talking about what Skyclarys does and how important it is to people with FA. And maybe I can just kind of talk a little bit about what slowing of progression actually can look like for patients with FA based on conversations I've had with patients across the country. As the previous speaker mentioned, Skyclarys slows progression of neurological symptoms by 55%. What does that actually mean? So for someone who is still able to walk independently, that might mean that they are able to continue walking independently for longer than would be possible if they didn't have Skyclarys. For someone who is already in a wheelchair full time, that might mean that they're able to transfer by themselves between a wheelchair and bed or the toilet or all of those types of things for longer. It might mean that they're able to feed themselves for longer or type and write for longer, which means they'd be able to maintain employment for a longer amount of time. FA, again, is progressive, and because the disease gets progressively worse, families have to spend a lot of time and expenses continuously modifying their lifestyles, retrofitting their homes for accessibility, hiring personal care assistants when it gets to the point where someone has really lost the ability to perform all activities of daily living independently. So any amount of slowing of that progression is really beneficial to patients at any stage in the disease. Again, whether they're able to walk or whether they're in a wheelchair, they'd still benefit from slowing of progression if that means they can retain some of those fine motor skills or even the ability to continue speaking and being understood by their loved ones. I would just encourage the board to cover Skyclarys to the FDA label, and the FDA label means that anyone who has genetically confirmed FA who's over the age of 16 is eligible for the drug. And this is something that FARA has been encouraging with all of the Medicaid hearings we've attending, because slowing of progression is really a clinical benefit relevant to people at all stages of the disease. And thank you so much for allowing public comment, and I'm happy to answer any questions or talk more about FA if that's helpful.
Thank you so much, Kellen. Appreciate your comments. Very good. So now let's move on to our next speaker, which is Dr. Lubelsi.
Good morning. Can you hear me?
Yes.
Okay, wonderful. Good morning. My name is Bessel Belzic, and I'm a pharmacist and a health outcomes liaison at Eli Lilly and Company. I'll be providing testimony on tirzepatide, brand name Zepbound, today. Zepbound is a GIP and GLP-1 receptor agonist and received FDA approval as the first and only prescription medicine for adults with moderate to severe obstructive sleep apnea and obesity late last year. Zepbound is also indicated to reduce excess body weight and maintain weight reduction long-term in adults with obesity or adults with overweight in the presence of at least one weight-related comorbid condition. Clinical guidelines recommend treatment of obesity in patients with OSA. In the design of the SURMOUNT OSA trial, it was hypothesized that the reduction of body weight, specifically excess adiposity surrounding the upper airways and the abdomen, would improve OSA severity. The SURMOUNT OSA trial included 2 separate trials to evaluate the efficacy and safety of the maximum tolerated dose of tirzepatide in adults with moderate to severe OSA and obesity. The first trial included participants who were unable or unwilling to use continuous positive airway pressure or CPAP therapy. And trial 2 included participants who had been using CPAP therapy for at least 3 months and plan to continue. When used appropriately, CPAP therapy improves AHI and reduces symptoms related to OSA, but it does little to alter the underlying pathophysiology of OSA, and more than 50% of patients recently initiated on CPAP discontinue within 1 year, according to data. Participants in both trials who received tirzepatide had significant reductions in AHI and in the sleep apnea-specific hypoxic burden, in addition to significant reductions in body weight. Up to half of participants who received tirzepatide achieved disease remission or reduced their severity to mild asymptomatic OSA. The safety profile of tirzepatide was consistent with that observed in previous studies. Mild to moderate gastrointestinal events were the most frequently reported adverse events, occurring primarily during the dose escalation period. Full safety information, including the boxed warning for risk of thyroid C-cell tumors, can be seen in the prescribing information for Zepbound. Thank you for considering the addition of Zepbound to the PDL that would allow appropriate patients in the state of Utah with moderate to severe OSA and obesity to access Zepbound. I'll be happy to take any questions.
Great. Thank you, Dr. Lubelczyk, for your comment. And lastly, we'll move on with presenter Amy Hale. Dr. Hale.
Good morning. My name is Amy Hale, and I'm a pharmacist and principal scientific account lead with Johnson & Johnson Innovative Medicine. I want to thank you for this opportunity to speak to you this morning about Spravato, or esketamine nasal spray. Spravato is a non-competitive NMDA receptor antagonist indicated for the treatment of treatment-resistant depression in adults as monotherapy or in conjunction with an oral antidepressant, and depressive symptoms in adults with major depressive disorder with acute suicidal ideation or behavior in conjunction with an oral antidepressant. Spravato has a box warning for sedation, dissociation, respiratory depression, abuse and misuse, and suicidal thoughts and behaviors. Spravato is a Schedule III controlled substance available only through a restricted program called the Spravato REMS. The FDA issued an alert in February 2022 and October 2023 due to increased safety reports following the use of compounded ketamine nasal spray and compounded oral products, respectively. Ketamine is not FDA approved for the treatment of any psychiatric disorder, and the FDA recommends healthcare professionals be aware of the potential risks associated with compounded ketamine products. The efficacy and safety of Spravato were studied in multiple trials for treatment-resistant depression. As monotherapy, it was studied in a multi-center phase 4 double-blind randomized placebo-controlled trial. In the double-blind phase, patients are randomized 2 to 1 to 1 to receive placebo nasal spray, Spravato 56 milligrams, or Spravato 84 milligrams. In the open-label treatment and observation phase, patients received either dose of Spravato with or without the standard of care therapy. The primary endpoint of change in the MADRS total score from baseline to day 28 showed statistical significance and clinically meaningful improvement in Spravato compared to placebo. The key secondary endpoint of change in the MADRS total score from baseline to day 2, or approximately 24 hours after the first dose, also showed statistically significant improvement in the Spravato groups compared to placebo. Overall, rates of patients who reported treatment-emergent adverse events during the double-blind phase were 72.4% for Spravato 56 milligrams, 75.2% for Spravato 84 milligrams, and 49.2% for placebo. Treatment-emergent adverse events rates in the open-label phase were reported based on the previous double-blind treatment: 64.6% in Spravato 56 milligrams, 63.8% in Spravato 84 milligrams, and 73.4% in placebo to Spravato patients. The majority of treatment-emergent adverse events were transient, and no deaths were reported in either the double-blind or open-label phases. The most common adverse events in patients treated with Spravato monotherapy observed in treatment-resistant depression include dissociation, dizziness, nausea, sedation, vertigo, hypoesthesia, anxiety, lethargy, increased blood pressure, vomiting, feeling drunk, and headache. In summary, Spravato is indicated for the treatment of treatment-resistant depression as monotherapy or in conjunction with an oral antidepressant, and for major depressive disorder with acute suicidal ideation or behavior in conjunction with an oral antidepressant. Please see the full prescribing information for complete information. I respectfully request your consideration to adjust prior authorization criteria to reflect the Spravato monotherapy approval for treatment-resistant depression. I sincerely thank you for your time today, and I'm happy to answer any questions you may have.
Excellent. Thank you, Dr. Hale. And Dr. Weinstein, I turn the time over to you.
Thank you. We are going to move the consideration of Zepbound up on the agenda. Is that correct?
That's right.
Yeah.
Yes.
For time considerations, and we have a review document, correct?
Yes. Presented by our pharmacist, Dr. Park.
There we go. Thank you.
Hello, does everybody hear me okay?
Yes.
Okay, perfect, thank you. So this is the revised PA for the Zepbound. So it's a patient 18 years or older, is it prescribed by or in consultation with neurologist, pulmonologist, otolaryngologist, or other sleep medicine specialist. Does the patient have a diagnosis of moderate to severe OSA confirmed by apnea-hypopnea index 15 or higher as determined by an in-lab attended sleep study or polysomnography? And then they can put the baseline AIG score here. Does the patient have a body mass index of greater than or equal to 30 kilogram per meter square? And then they can put baseline BMI and then body weight. Has the patient been adherent to positive airway pressure or PAP for at least 70% in the last 6 months? Last 6 months, and will continue on PAP in combination with tirzepatide unless intolerant or other rationales given. Does the provider attest that the patient has none of the following contraindications: a personal or family history of medullary thyroid carcinoma, and B, personal history or multiple endocrine neoplasia syndrome type 2. Has the provider verified that the patient does not have type 1 or type 2 diabetes? Will the patient continue on medically appropriate exercise program and an appropriate calorie-restricted diet supervised by a registered dietitian? Does the provider attest that the patient is not taking another glucagon-like peptide 1 or GLP-1 receptor agonist or gastric inhibitory peptide or GIP and GLP-1 receptor agonist medication? And for reauthorization, has the patient experienced a decrease in AIG from baseline of at least 20% or change in OSA severity status to remission or mild non-symptomatic OSA defined by AHI less than 5 or AHI between 5 to 14 and Epworth sleepiness scale less than or equal to 10? Has the patient experienced a decrease in body weight from the baseline of at least 10%? Has the patient been adherent to PAP for at least 70% in the last 6 months and will continue on PAP in combination with tirzepatide unless intolerant or other rationale is given? Okay, any questions on the revised one?
I do have a question. I'm not recalling the current form, so it's just a question about having the patient under supervision of a registered dietitian. Is that something that we can reasonably expect? And is that something that we know is standard? This medication being prescribed for OA. That would assume that they have other services in place. So just from a clinical perspective, maybe other folks can speak to that. Thank you.
So basically the patients experience the improvement on their OSA by losing weight. So losing weight must be like combined with not only the pharmacotherapy but also exercise and reduced calorie diet. So that's why we required it to maximize the benefit for the improvement on the OSA.
Thank you. I'm not questioning the rationale at all. I think that kind of comprehensive program is most likely to be successful. It was more just a practical question for service access, and if these patients in Medicaid will have ready access to the dietitian, they'll already be in some related program.
Yeah, I believe Medicaid provide dietitian services.
Are there any other questions or comments from the board? Not, I think we need a motion to approve the amended or revised reauthorization criteria for Zepbound.
This is Laura. I'll motion.
It's Jennifer. I'll second.
Thank you. All in favor, please indicate aye.
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 Okay, thank you.
Thank you very much. Let's see. We're going back to the top of the agenda, Luis, or?
Yeah, so next is the Alhemo PA criteria by noon, Dr. Nguyen.
Thank you.
Good morning, everyone. This is the proposed criteria for the Alhemo. Criteria for approval, one of the following criteria must be met. Is the patient 12 years of age or older? Does the patient have one of the following diagnoses? Hemophilia A, congenital factor A deficiency with factor A inhibitors. Hemophilia B, congenital factor 9 deficiency with factor 9 inhibitors. Is the medication being prescribed by or in consultation with a hematologist specializing in the treatment of hemophilia? Does the provider attest that the patient will not be taking any of the following concurrent with Alhemo, such as Hemlibra, Hemdazi, or any bypassing agent for routine prophylaxis? Having an on-hand supply to treat an acute bleed is acceptable. We provide some example of the bypassing agents in the criteria, such as the Novo 7, 7-FAC, and FAVA, which is an anti-inhibitor coagulation complex. If the patient have hemophilia A, does the patient have a history of a positive test result for factor A inhibitor of equal or more than 0.6 Bethesda unit per ml? If the patient have hemophilia B, does the patient have a history of positive test result of factor 9 inhibitor of equal or more than 0.3 Bethesda unit per ml? Does the provider have plan to measure hemoplasma concentration by concizumab enzyme immunosorbent assay between 4 to 8 weeks after the initiation of treatment? Does the provider has a plan, including patient educations, to manage acute bleed? The reauth criteria is, has the provider submitted an updated letter of medical necessity or updated chart note demonstrating a positive clinical response, such as reduction in bleeding events, in the severity of bleeding episode, in the number of bleeding events that require treatment, or in the number of spontaneous bleed? If this is the first request for maintenance dose, has the provider submitted documentation including the patient concizumab plasma concentration? Initial authorization is up to 3 months and reauth is up to 1 year. We have the note to monitoring the development of thrombotic events, especially for patients who receive the frequent doses of breakthrough lead treatment, or conditions in which tissues factor is overexpressed. Monitor and inform patients of hypersensitivity reactions, including erythema, rash, pruritus, and abdominal pain. Laboratory value of fibrin D dimer and prothrombin fragment 1+2 may be increases in patient receiving concizumab. Any questions on the criteria? We have shared the criteria with the hemophilia treatment centers as well as the ACO for awareness.
Any of our board members with expertise in this area have any comments or recommendations for any adjustments?
As mentioned, the ACO is reviewed, and we are good with the criteria.
Thank you for confirming that. If there are no other questions or discussion, I would entertain a motion to approve the authorization criteria.
I'll mention.
Thank you. Do we have a second? I think I'm able to second, or, oh no, Dr. Seacreed, thank you. All in favor, please indicate so.
Aye.
Aye.
Aye. Thank you very much. Next on our agenda, if we still have a minute or two.
All right. So I will be presenting the criteria for QFITLIA at this time. And so it's for patients 12 years of age or older. Does the patient have one of the following diagnoses? So hemophilia A with or without factor VIII inhibitors, hemophilia B with or without factor IX inhibitors. Is the medication being prescribed by or in consultation with the hematologist specializing in the treatment of hemophilia? Does the provider attest that the patient does not have any of the following: a history of arterial or venous thromboembolism, significant valvular disease or atrial fibrillation, coexisting thrombophilic disorders, hepatic impairment? Does the patient have the appropriate baseline lab values required to start therapy with this medication? And so these include antithrombin activity is 60% or greater prior to treatment initiation, platelet count greater than 100,000 microliters, sorry. And then the EGFR greater than 45 milliliter per minute. The requesting provider plans to adhere to QFITLIA dosing per FDA label, which includes a maximum starting dose of 50 milligram every 2 months, and also a maximum dose of 50 milligram monthly. So that's after the starting dose is implemented. Please note, dose escalations will require a new prior authorization with documented AT activity greater than 35% after 6 months of consistent dosing, and pharmacy claims will be verified. Does the provider attest to the following recommendations for monitoring and counseling? Thrombotic risk monitoring is in place before and during QFITLIA use. Antithrombin activity measured with an FDA cleared assay per label, kept between 15 to 35%. Check monthly liver function tests for 6 months at baseline and after dose increase, then periodically. Monitor for signs and symptoms of acute and recurrent gallbladder disease. Gallbladder symptoms monitored throughout treatment. If on CFC or BPA prophylaxis, those agents will be discontinued within 7 days of QFITLIA initiation. For the reauthorization criteria, has the provider submitted an updated letter of medical necessity or updated chart notes, demonstrated positive clinical response and LFT monitoring per prescribing information. If the patient had Qfitlia treatment interruption due to worsening liver test abnormalities, does the provider attest that the patient has not experienced ALT or SAT elevations greater than 5 times upper limit of normal, or total bilirubin greater than or equal to 2.5 milligram per deciliter after restarting Qfitlia? And that's per the package label. Does the provider attest to completing the medication monitoring recommendations outlining criterion 7 above? So right here, we want that to continue. And then number 4, if requesting a 1-year reauthorization, has the patient reached a target dose with AT activity between 15 to 35% after 6 months of stable dosing? And so the initial authorization is up to 6 months, with the reauthorization up to 1 year. And then on the note, we just included the black box warnings, which I've already gone over during the presentation. Any questions?
Again, just calling on our colleagues with expertise have reviewed this, and I would think in the absence of any additional discussion, comments, or adjustments, we can entertain a motion to approve.
So move.
And do I have a second? Second. Thank you. All in favor?
Aye.
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 Okay, thank you. Just looking at whether we have time, Luis, to continue with the board actions that were on our agenda for today.
Yeah, so the next one would be the Sky Claris. And I think that we still might have time for that one.
Very good. Let's bring that one up. Sorry, I'm just flipping back and forth between my screens. That's you also. Thank you.
Oh, that's right. Sorry, I apologize.
No, not at all.
All right, so Sky Claris, and I have it. Okay, right here. And I'm going to make it a little bit bigger. Okay, so starting with criteria number 1, is the patient 16 years of age or older? Number 2, does the patient have a diagnosis of Friedreich's ataxia as shown by a confirmed presence of a mutation in the frataxin gene? Is the medication being prescribed by or in consultation with a neurologist or a physician specializing in neuromuscular disorders? Will the treating provider monitor hepatic transaminases, total bilirubin, B-type natriuretic peptide, BNP, and lipid abnormalities prior to starting Sky Claris and during treatment according to FDA labeling? And then, has the patient been assessed using the modified Friedreich's ataxia rating scale, mFARS, and has a score between 20 and 80? And what is the patient's baseline mFARS score? Reauthorization criteria: has a patient had clinically significant improvement or stabilization as shown by the modified Friedreich's ataxia rating scale score? And number 2, is the medication being prescribed by or in consultation with a neurologist or a physician specializing in neuromuscular disorders? Initial authorization is up to 1 year, with the reauthorization also up to 1 year. Any questions?
I would just make a comment based on our public input regarding criteria 5 and 6 there, which relate to the mFARS. Having been a clinical investigator myself and also a clinician, it is sometimes more than can be expected to have the use of scales like this in clinical practice. So I'm wondering if we want to adjust that a little bit to say if the patient has been assessed, is their score, what the score is, but we might want to make an element that is the documentation of the neurologic examination and functional assessment, which would be more likely to be followed, by the clinical experts taking care of this patient. How does the board think about that?
I agree. I also have done research, and rating scales alone don't often tell you the entire story, and sometimes they are not in the public domain either, and the providers may not be familiar with them. So I think documentation of the neurologic exam as well as function would be more likely to actually demonstrate their baseline as well as for reauthorization and improvement.
Okay, so just for clarification, include not only the request for the scale or score, but also include documentation in terms of the patient's function at baseline, apart
And
from the scale.
Right, and I just want to clarify for reauthorization, not necessarily improvement, but at least slowing of progression, perhaps, because it's based on the natural history and course of the illness, there likely still will be decline. So there may be slowing of progression or stabilization, but not necessarily large improvement. Whereas, for example, someone who's already in a wheelchair likely will not regain the ability to ambulate independently.
Correct. Thank you for that input. So we'll revise.
Are there any other comments from the board on this?
So are we saying either a rating scale score or clinical documentation showing improvement in the assessment of the member or the patient? Is that what we're saying?
I think what I was trying to say was for the initial, like I might change criteria number 5 to the documented neurologic exam and functional assessment. That's going to be in the clinical records, and combine criteria 5 and 6 to say the patient has had this scale. What is the number? There may be a clinic where there are, specialists who are clinical investigators, and maybe they do use it. But I think I would make that a requirement. However, I would make the clinical assessment a requirement. And then to Dr. Siegfried's point, in the reauthorization, we do have number 1, clinically significant improvement or stabilization. We would just modify that to say as documented in the clinical assessment. And if the scale's being used, they can include that as part of their clinical information to support reauthorization.
Thank you.
Does that make sense?
Yes.
Okay, are we able to take an action with those amendments, Luis, or do we need to see the revised criterion?
Yes, it seems like we have the main criteria. We'll just add the functional assessment, clinical assessment to the scale. And then for the reauth criteria, like Dr. Siegfried was saying, adding the slowing of the progression as part of positive response. And so based on those two things, I'm not sure if we need to bring it back, but definitely defer to the board, see what they want to do.
If the board's inclined, I think we could have a motion to approve with these suggested adjustments to the form. Any objections to that? If not, I'd take a motion.
I move to approve.
Second.
Thank you. Can we have a vote? All in favor? Aye.
Aye.
Thank you so much for that. And time permitting, where are we, Louise, here?
So yeah, it looks like we are out of time. So we will bring Spravato at next meeting, just a revision for that PA.
Okay, unless you think we could do it in 1 minute.
I can try to do it pretty quickly. There's only one change.
Yeah,
Right.
just
This
that
is
one.
an amended form. I prefer to take care of it if folks can stay on for a minute or two.
Thank you.
Thank you. Go ahead.
All right.
Is everyone able to see?
There we are.
Perfect. So the only change that we have made is modifying the original criterion 2 and simplifying it into 2 different criterias. So does the patient have a diagnosis of major depressive disorder? And is their MDD characterized by one of the following: treatment-resistant depression, acute suicidal ideation, and then separating into number 3, is the medication being prescribed by or in consultation with a psychiatrist or mental health specialist qualified in the diagnosis and treatment of psychiatric disease, certified licensed scope of practice, etc., with prescribing authority. It was just previously combined into one singular criteria. So that's the only change we have made.
It looks like that clarifies the form. Are there any comments or questions from the board?
And I can show you guys the old one if needed.
I think you were very clear in explaining that. Thank you so much. If nothing further from the board on this, I would take a motion to approve the amended form. Motion to approve and second.
I can second.
Thank you so much. Can we have a vote? All in favor?
Aye.
Aye. Okay, I want to thank everybody for excellent work today and an ambitious agenda. And I think we accomplished a lot. And thanks for staying over 2 minutes so we could finish it. And if there's anything, to follow up, please direct that to Dr. Moreno or myself. We'll be happy to address.
Thank you, team.
Can we
Thank
have
you.
a
Can we
motion?
motion?
We'll take a motion to adjourn.
Motion.
Second. Thank you all. Have a good month. We'll see you in June.
Thank you.
Thank you.